My name is Steen. I'm one of the EM residents.
My name is Huyam, the other EM resident.
And we're joined by Eddie Mejia and Dr. Syl Bandar, one of our attendings. So we went ahead and made this video mostly because we remember being a little lost on our first trauma shift with regards to how to perform the exam. So basically we're going to be going through what we need to do for level 1 trauma activations, what we need to do for level 2 trauma activations, and in detail going into the secondary exam. And then we're also going to go ahead and talk about some general tips.
Yeah, so hopefully you guys can take all this in. You don't have to take it all in at once, but watch the video several times and maybe get a hang of it. So.
Alright, so we're going to start off talking about the level 1 trauma activations. They're primarily going to be taken by our upper levels, but sometimes it happens where multiple level 1s coming back to back, so it's important for you to be ready to rise to the occasion. So you're mostly going to be standing right over here at the head of the bed. Everyone has their own roles. For emergency medicine, our main roles are going to be ABCs, taking good ample history, and doing a fast exam if it's indicated. Alright. So for the level 1 trauma activations, the first thing you want to do is make sure you get everything ready. So first you start off getting yourself ready. You'll go ahead and put your gown on, put your lead on first, put the gown on over that, and then make sure you have your stethoscope and your pen light on outside the gown, because you're going to need that for your primary survey. Next, you go ahead and grab the ultrasound and the glide scope if the patient's not already intubated, in the event that you need to intubate them. You go ahead and bring these in the room, and then you go ahead and get the room ready for the patient before they get here. So we're going to start off with all the airway equipment, because that's of course one of the most important things. If you hear that the patient's not intubated, you want to go ahead and make sure you have your BVM ready and hooked up and already inflated. Have a non-rebreather also hooked up, and this is all for pre-oxygenating the patient in the event that you will need to intubate them. So you have your non-rebreather ready, you have your BVM ready, and you get your suction also ready. And you have your suction over here hooked up. You turn it on to continuous, and you turn it on all the way to full back. The last thing we want to get ready is the intubation box. So make sure you have this ready. If it sounds like it's going to be a case where you'll likely need to use it, just go ahead and open the airway box. Make sure you check your tube, get the stylet in there, and make sure the cup inflates on the tube. So you're now ready for the patient to come in. Alright, so when EMS initially comes in, it's really important that we ask the room to all quiet down so that we can really listen to the story. Sometimes you might need to just loudly say, hey, can everyone please be quiet so we can listen to EMS's story? Sometimes it can be hard to speak up as an intern, but it's important to go ahead and do so. Another thing is that sometimes your initial instinct is going to be to put your stethoscope on and start listening to the patient, but try to avoid doing that. Really make sure for that initially when they come in, just listen to the story, because once they leave, you don't have the story anymore. So it's really important you go ahead and pay attention initially.
Okay.
Alright, so now that you've listened to EMS's report, we're going to start off with our ABCs. So you're going to start off by assessing the patient's airway, so you go ahead and ask the patient a question. So what's your name? Hui. So it's important you carefully listen to how they pronounce their name and listen for any gargling. If you hear any of that, you can go ahead and suction out the airway. Your main two interventions will be suction and jaw thrust. So you suction out the airway if you need it, and if you think they need an airway intervention, you perform a jaw thrust for them. So after you determine the airway is intact, it's important you loudly say that so the whole room can hear it. So airway is intact, now you can move on to assessing the patient's breathing. So you're going to do look, listen, and feeling. You look for the trachea to be midline. You look for any signs of trauma on the chest. The patient will likely already have their shirt off at this point. And once you can see that the patient has bilateral chest rise and midline trachea, you can go ahead and listen to the lungs. And you're not just listening for absent breath sounds or present breath sounds, it's important to quantify it. So listen for diminished breath sounds, because that can be a sign of a pneumothorax or hemothorax. It's actually kind of rare that you'll have completely absent breath sounds. So once you listen, you go ahead and feel for any crepitus that might be on the neck or on the anterior chest, and feel for any signs of trauma or penetrating wounds. So after you assess the patient's breathing, you loudly announce again that the patient has bilateral breath sounds, there's no signs of trauma, and have symmetric chest rise and no crepitus. Next, you go ahead and assess the patient's circulation. So you feel for carotid pulses, one side at a time. And then you can announce that the patient has bilateral carotid pulses. Once you do that, you go ahead and assess the patient's disability or neurologic status. So you do that by first looking at the patient's pupils, and then asking the patient to follow a simple command. So I like to ask them to give them a thumbs up and wiggle their toes. So you look for that. So after you do that, you can now calculate the patient's GCS. You've looked at their pupils and you've got the command symbols. The last part is actually going to be exposure of the patient, which will be mostly taken care of by trauma surgery. They'll be exposing the patient and doing their full secondary exam. ATLS, we always learn A, B, C's. It's not always that rigid, right? There will be some times where C takes the priority. For instance, if the patient has an actively bleeding wound, you're going to be controlling that before you pretty much do anything else. Another thing that's really important to understand is that before you intubate a patient, sometimes you will also have to think about their circulation. So if the patient is very hypotensive, you'll be thinking about that you have to resuscitate the patient before you intubate. So you'll be giving the patient blood products like PRBCs and plasma, and once you get their pressure up a little bit, then you can go ahead and start thinking about intubating the patient. Because once you intubate the patient, you'll be placing the patient on positive pressure ventilation, and that can cause a decrease in the patient's blood pressure. So it's really important to remember always resuscitate before you intubate, especially in trauma patients. After you've completed your primary survey, the next thing you want to do is go ahead and get an ample history from the patient. That's asking the patient about their allergies, medications, and ask the patient what medicines they're taking, but then also specifically ask them about certain medications such as aspirin, Plavix, warfarin, Coumadin, DOACs, beta blockers. Those medicines are really important to know before this patient is going to go to surgery. You also want to know what the patient's past medical history is, when their last meal was, and what were the events that kind of led to them coming in today. After you've got a good ample history from the patient, if you don't have help in the room, you're going to want to go ahead and do your FAST exam on the patient if the FAST exam is indicated. After you do your FAST exam, the last thing you want to do is, before trauma surgery leaves the room, is discuss with them what their findings were on the secondary, just to make sure that you guys are both on the same page. Because you're going to still have to document a secondary exam on the patient, and in addition to that, you're going to be the one ordering all of the imaging. So it's important that you know everything that's going on with the patient and everyone's on the same page. All right, so we're just going to quickly recap all the important learning points from this. So 1, it's important to prepare yourself and get ready for the case. 2, it's important to listen to EMS's handoff. 3, it's important to get a good ample history from the patient. 4, it's really important that you do get your ultrasound and get your FAST exam in after you do your primary survey. And 5, it's really important that you and trauma surgery are on the same page and confirm the findings so that you know what to document and what orders to put in.
So we're going to move on to the next part of the exam. This will be a level 2 exam. We'll be doing the primary survey, which we've already covered in the prior videos, and we'll be doing the secondary survey as well as in its entirety. The point of this whole section is to kind of make sure we give you some good tips and tricks so you don't miss things that are commonly overlooked, and also stuff that might not be covered in ATLS, and how things are usually done at our shop, so it'll give you a better idea. Some things to keep in mind, sometimes these patients are triaged at level 2, but usually you come in, they look sicker than what you anticipate. You gotta triage up to level 1. So those are things to keep in mind, but with that, let's get started. So the secondary survey can be broken down to 5 different parts. The first one being head, face, neck. The second one being torso and pelvis, which covers the chest, abdomen, pelvis. And the third one is the upper extremities, followed by the lower extremity, and lastly, the back, which we'll have the patient roll over. So the first thing I like to look at is the head, right? So the first thing I do is I'll inspect the scalp and the forehead itself, looking for any signs of deformity or hematomas or any lacerations. Then I'm going to start feeling around for any tenderness in the forehead, as well as the temporal area, the occiput, and the top of the head. Now sometimes there might be dry blood obscuring any possible laceration. So a tip that you can do is take some 4x4s, hydrogen peroxide and normal saline, pour some hydrogen peroxide into the 4x4, grab some saline, mix it in there, and it breaks down the blood clot pretty well, so you can better take a look at the laceration below. Once you see a laceration of the scalp, just keep in mind how deep it is and if it's involved in the glial area. That way you might need to suture it later on once you have time to come back to. So the next part of the exam, we're going to take a look at the ears as well as the nose. So what I like to do with the ears is lift the ears forward and look behind it for any ecchymosis or bruising. This is called battle sign. It leads to possible, it points to possible basal skull fractures. Then you're going to look for any drainage from the ear, such as CSF or blood. And then you're going to take an otoscope. And if you don't have one in the room, now's the time to go outside and ask a nurse, or if you can't find a nurse, find it yourself, and take a look, close look at the eardrum itself. Look for hemotympanum. This is important because this is a very overlooked part of the exam, and it can help point us to signs of basal skull fractures, and it's really easily done. Now the next part of the exam is also the nose, which most people don't really look at. But what you want to do is, grab a pen light or the, otoscope, and take a look inside the nose, making sure you look for any signs of CSF drainage or any septal hematomas. Septal hematomas that aren't drained can cause necrosis of the septum and lead to perforations, which will lead to complications further down the line. So the next part of the exam is we're going to start palpating the forehead and the face, looking for any signs of tenderness. So start at the forehead here, and right where the maxilla and the zygomatic arch is, right here. You're feeling for any tenderness that might point to possible facial fractures. And then next, we're going to move on to the eyes itself, starting with inspection. You're looking around the eyes first for any paraorbital ecchymosis. And if you see any like tarsal plate sparing and bruising around the eyes, it's pointing to, concerning for what we call raccoon eyes, which can point to a basilar skull fracture as well. And then, if the patient's eyes too swollen to do an exam, you can also take 2 paper clips, bend them at 90 degrees each, and pull them apart. But we'll save that for a separate video. And the next part is I want to take a look at the pupils themselves. So open the patient's eye real quick, take a look at the pupils. What we're looking here is, in the setting of traumas for dilated pupils, just in the sense that if you have an intracranial bleed or hemorrhage, this could cause increased intracranial pressures, leading to the pupils being dilated. If the patient is also taking drugs, pinpoint pupils can also point you to the reason why they're altered. So all the more reasons to look at pupils. Then the next step is I want to assess their visual acuity. If you got a Snellen eye chart, now's the time to pull it out and use it. If you don't, then you just go ahead and do a gross acuity test with your fingers and come back later with a Snellen chart. So right now I'm going to cover one patient's eye. How many fingers do you see? 2. And we'll cover the other eye?
2.
Okay, so the patient's visual acuity is intact. But if it wasn't, then we come back later and do a more detailed exam with a slit lamp, Woods lamp, whatever you have on hand. That way we can take a close look at the eye. Next thing we want to look for is any signs of conjunctivitis or hyphemas. Especially in car accidents, when the airbags blow up, you can suffer alkali burns or trauma to the eye. So you can see conjunctivitis, or you can see hyphemas as well. Those are all things to keep in mind of when you take a look at the eye.
Also, a fun fact is that the airbag, the speed at which it deploys is faster than the speed at which you can blink. So that's why people get corneal abrasions.
So the next part of the face exam is we're going to take a look at the mouth itself. So we'll expect from the outside how the patient open their mouth, they're able to comply. Can you open your mouth? So look inside the mouth for any, obvious signs of trauma or laceration. Then you're going to want to flip the lips. This is a very overlooked part of the exam that most people don't do, but it's important to make sure that there's no laceration in their lips that can be easily repaired later on. And then have the patient open all the way up and have them bite down. Do you feel like you're missing any teeth or your bite's off? This is an easy way to assess whether there's any broken, teeth or if their jaw's dislocated, because the patient knows their mouth best. And if you have any concerns for any missing teeth or chipped teeth, then you're going to want to take a chest x-ray to make sure there's no aspiration going on. Then the next thing you want to do is assess for stability of the face. So have them open your mouth, and then you're going to grab the maxilla and move it back and forth, and then you're going to do the same thing with the mandible itself, looking for instability. This can all point to four fractures, which is a significant sign of trauma to the face, and will require further imaging.
On inspection, if you notice the patient is drooling or having difficulty opening their mouth, what we call trismus, this will all point to signs of mandibular fracture. Another simple thing you can do is grab a tongue depressor, and then you're going to insert it on the molars on both sides, the right and the left, and you have them open up, and then bite down. And what you're going to do is you're going to twist the tongue blade, and if they can break it, there's a good chance that they don't have any mandibular fracture.
So the next part of the exam is going to be the neck. Sometimes in level 2s, patients will come in without a C-collar. Sometimes they will come with a C-collar. Just depends on the mechanism. In our example, we'll assume the patient needs a C-collar. What you're going to do first is take the C-collar off, and you're going to have some assistance here. Don't take it off completely, just undo the straps. Have someone hold the patient's head, neck, and midline. Then you're going to take a look at the neck itself. Look at the trachea, make sure it's midline. And then you look for any signs of what we call seatbelt sign, which is just ecchymosis and a seatbelt distribution. This could point to possible vascular injuries that might require further CT angio for imaging. Then you're going to feel around the neck for any blood or hematomas that might form up around the carotids. This all could point to signs of vascular injury as well. So make sure you're a little bit more thorough around the neck, especially when you see a seatbelt sign or any signs of hematomas. So the next part of the exam is going to be the torso as well as the pelvis. Looking at the chest, the abdomen, and pelvis itself. As always, I'm going to start with look, then feel, and then kind of just compress whenever you can. So we'll look first, make sure the patient's already exposed, and you look for any signs of gross deformities, lacerations, especially in the axilla as well, commonly missed down here. And you look for ecchymosis as well. You want to look for ecchymosis in the seatbelt distribution, what we refer to as a seatbelt sign. What this conveys to you is that there's a significant amount of energy transferred to the patient's abdomen as well as the chest. And then you're going to want to start palpating, starting from the top to the bottom. The clavicle is most commonly missed, so make sure you start from the top and work your way down. That way you don't miss anything. So you start with clavicles, you feel for any tenderness here. Then you're going to work your way down to the interior chest. And then you're going to work your way down here. And then go lateral, pushing down for any tenderness. And then you're going to go to the belly. As always, 4 quadrants that you've learned before. You'll start each one just pushing down, looking for any signs of tenderness with palpation. And then you look for the same ecchymosis with the seatbelt sign we talked about before. And then moving on to the pelvis, we're going to palpate a couple areas. We're going to do lateral compressions. And then you're going to find the pubic symphysis and push down here, assessing for any tenderness. It's important to not rock the pelvis, as you can cause more shearing injuries to any veins if there's a fracture, or even arteries and shearing injuries to any vasculature in the pelvis itself. And so you got to be careful when doing that. So we recommend just doing lateral compression as well as palpating the pubic symphysis. And if you have any tenderness there, consider x-raying the pelvis. And then there's a GU exam, but we'll defer for now. But what you're looking for mostly is this blood in the meatus or any signs of injury around the genitalia.
All right, so now that we've finished the head, face, neck, and torso, we can move on to the upper extremity and lower extremity exam. So just a general rule, we're going to start distally and we're going to move proximally. And it's really important that we look, range, and feel everything. It's really important we feel every single part of the upper extremity and lower extremity. So just start off with inspection. We're going to look for any gross deformities, lacerations, abrasions, bruising. After we look at everything, we're going to go ahead and range everything. So start off with just having them grab our fingers. So it tests our grip strength. And then while they hold on, you can text extension and flexion. After you do that, you can flex and supinate, and then extend and pronate. And then after that, you can go ahead and flex the arm, bring it down, and then do internal and external rotation. You do the same thing for both sides, essentially. After that, we'll go ahead and feel everything. So you can just go ahead and feel all of the fingers. Another really important thing is go ahead and feel the snuff box. This is a really commonly missed injury. So you'll just go down the thumb right over here and just go ahead and feel the anatomic snuff box. Once you feel that, you go ahead and feel the carpal bones, the forearm, radius ulna, move up to the joint, move up the arm, and then you get over here. And then if you haven't felt the clavicle, again, make sure you don't miss the clavicle. You do the same thing on the other side.
So, fun fact. When you're driving, your hands are on a steering wheel like this. You've got a force coming from the front. This is akin to a fusion injury or fallen outstretched hand. Imagine your steering wheel like here, holding here, and force going right on your skateboard. It's a commonly missed injury, what we call an occult injury in trauma, and it's something you should keep in mind for every trauma you see.
So now that we're done with the upper extremity, we're going to move on to the lower extremity exam. And the first thing is that we're going to have to obviously get the patient undressed. So we're going to get the shoes off, get the socks off. If the patient is wearing jeans, it's important to get the jeans off because it's impossible to do a thorough secondary if the patient remained fully dressed the whole time, right? So it's important to get the patient undressed, and if the nurses are there, they can also help you out with that. So once you have the patient undressed, then you can appropriately look at everything. The first thing you do is inspect the lower extremity. So you obviously look for any signs of external rotation, look for any signs of shortening. These can all indicate hip dislocations, pelvic fractures. So it's important to be aware of that. And those are also things that possibly might indicate that you might need to upgrade this patient to a level 1 if you think that this patient's like out in the back hallway or something like that. So once you're done inspecting everything, you'll now go ahead and range everything, right? So we'll start off distally and move proximally. So you can dorsiflex, plantar flex. You can go ahead and range the toes as well. Once you do that, you can also make sure that you're ranging the knee, flexion and extension. And then also it's important to range, have your patient range the lower extremity while keeping the legs straight. And what this does is it ensures that the patient has their patellar tendon also intact. So you can go ahead and have a patient range up. And then this tells you that the patient's patellar tendon is also intact, right? So now that one more thing for range of motion, is to make sure that we do internal and external rotation of the hip. And this tells us that the patient's hip is also intact. Okay, so once we're done with the range of motion, we can move on to palpating everything. So again, we'll start off with the toes. Important thing to not miss here is a Liz Frank injury. So it's over here between the first and second metatarsal. So make sure we feel this. After we move on from here, we can move on to the ankle, and we can make sure we feel the distal 6 centimeters, the tibia and fibula. So feel this, the auto ankle rules. It's also important to go ahead and compress down the leg. And then important thing about this is that if the patient has an ankle injury, we're assessing for essentially Mason-New fracture, which is a problem with the syndesmosis between the tibia and the fibula. So we'll be compressing and feeling for any instability. And then it's also really important to feel the lateral head of the fibula, because this can also be involved in the Mason-New fracture. So lateral head of the fibula, palpate the knee, again, the patella, which is also used for the auto knee rule. And then you go up here and you can palpate over here near the hip.
So another thing to keep in mind is when you're assessing for the Liz Frank injury, you're going to test for instability between the first and second metatarsals. You can go back and forth like this. Why this is important is that, imagine if you're driving a car and your foot is on the brake, and you crash your car, and someone in front of you or into an object. There's a force coming from, the forward, the front part of the car hitting the back part of your foot, and then that's also akin to Fuchs injury, as you see in the scaphoid, and that can lead to instability in the metatarsals and the Liz Frank injury right here between the first and second metatarsal. So another thing to keep in mind.
All right, so one more thing to keep in mind is that for patients that had a fall from a height and that had an axial loading injury to their calcaneus, another thing to keep in mind is one, to obviously feel the calcaneus, but two, if they're continuing to have pain and tenderness, you need more than an x-ray to rule out injury to the calcaneus. You actually need a CT scan to properly rule out injury to it. And another thing to consider if you're strongly suspicious for a calcaneus injury is that the force can actually be transmitted up the lower extremity, up the spine. So if they're also having back pain, another thing to keep in mind is whether this patient is going to require spinal imaging in order to make sure they don't have an associated spinal injury from the axial loading force. All right, so one more thing to keep in mind is that if the patient you don't have a suspicion for a cervical spine injury, they don't have a C-collar on, you can actually go ahead and roll the patient on your own. So what you should do is just go ahead and make sure you have the bed rail up, and then the patient can go ahead and roll over onto the side on their own, and then you can perform the back exam just like we did last time. Another thing to keep in mind is that you can go ahead and roll back. Another thing to keep in mind is that if the patient does have an extremity injury, like a lower extremity injury or an upper extremity injury, it's always important to roll the patient towards the opposite side. So if he has an injury to his left, like let's say we suspect that he has a left knee fracture or a fibular fracture, you would roll the patient onto the right side, keeping the injured side elevated and supported with one of your assistants.
So, some general tips and pearls before we end this video. One thing you need to keep in mind is the mechanism of injury. It's important to ask EMS or even the patient, whoever's with the patient, what the mechanism of injury was, whether it's a rollover, frontal side impact, left side impact, or a fall from height. These can all lead to different things that you may want to consider in terms of imaging and exam. For instance, in a rollover where the car is flipped over multiple times, you might want to consider axial loading of the skull as the roof of the car hits the neck. So it's important to consider mechanism. Secondary, you need to make sure that you're risk stratifying these patients. Sometimes they'll be in the hallways as a level 2, when in fact they're unstable, possible pelvic fracture, and they need to be level 1. So always risk stratify patients when you first see them, make sure they're stable. And lastly, make sure you ambulate these patients before you discharge them. It's always important to make sure the patient can walk on their own, as this can be signs of occult injuries that you might have missed on the first time, such as pelvic injuries or hip injuries or even a tibial plateau fracture. And so it's always important to watch patients ambulate before you discharge a patient.
And document that you watch the patient ambulate and they're ambulating near their baseline. One, remember you're going to be doing this exam many times, so it's important you learn how to do it well and learn how to do it thoroughly. Next, again, it's really important that you make sure you range everything, palpate everything, and look at everything, right? It's important to make sure you get the patient fully undressed because you can't do a thorough secondary without actually having looked at everything. And again, it's just really important to make sure you ambulate the patient and watch them ambulate. And okay, one more last thing is that it's important to roll the patient while you have all the help in the room. Once everyone leaves, again, it's just really hard to get everyone back in the room. So just a quick few things that have really helped us out and that we've picked up over the years, so we just really wanted to pass them on to you, and you're all going to do great.